Hello everyone, my name is Michael Rivas. This is my presentation on multiple sclerosis. My eyes are a little squinty. I have really bad allergies, so bear with me. And I'm glad the video is actually working on this one. So, let's get right into it. So, multiple sclerosis. What is it? Multiple sclerosis is a chronic inflammation disease that damages the myelin sheath of the neurons in the central nervous system. So you can think of this as it's damaging your nervous system from within and causes outward effects. So common side effects are blurred vision, weakness, sensory loss, fatigue, pain, bowel bladder issues, and cognitive and emotional changes. So the believed cause of multiple sclerosis, although it is still very much unknown, is an autoimmune response caused by the environmental, infectious, and genetic factors, which the damaged myelin sheaths then form these scar-like plaques that inhibit nerve conduction. So if you think of your nerve cells as a big electrical system, this is essentially putting something blocking connection from A to B, or putting minute disconnects within. So how does this cause difficulty with exercise? Well, just think about it. Blurred vision, you're going to have disorientation. Weakness, obviously, is a huge effect of exercise. Sensory loss, you may not be able to control things. Fatigue, pain, all of those things that would affect exercise, and make this, as exercise physiologists ourselves, to really stress with them the importance of safety and working with them slowly. So I'll get into that later. And there are three main types of MS, but the most common is relapsing remitting MS, which essentially means that the side effects will hit them really hard, they'll slow down, then they'll come back even harder, slow down, maybe come back not as difficult or hard for them as before, but it just keeps coming back over and over. So this is just two diagrams I felt that really helped explain what was happening with multiple sclerosis. So on the right side, you can see a nerve fiber and the myelin sheath protecting this nerve fiber. Well, this is multiple sclerosis causing the scarred myelin sheath, and if you can see that it's causing weakness in the nerve fiber. So some interesting facts. 2.1 million people suffer from this worldwide, with onset of range from 20 to 50 years. This was shocking in the fact that at 20 years old, you could be dealing with something that will cause lifelong consequences. And it affects women at the rate 2 to 3 times that of men, which is something that is really prevalent right now. So, with currently no cure, and there are medications now that help slow the number of relapses and slow the course of the disease. So essentially we're dealing with a disease that is uncurable in terms of making it go away forever. And this was something somewhat like cancer that, yes, you might stop it for one time, but it will come back eventually. And it's not fatal, but it is debilitating. So another interesting fact that is specific to exercise when we're working with these patients is that they have a lower maximal aerobic capacity when compared to similar individuals in terms of age and sex. So essentially, you can have a 25-year-old male with multiple sclerosis and a 25-year-old male who's healthy, and they will have significantly lower aerobic capacities. And this causes a decrease in overall muscle performance. So let's move on to testing. Now, here's the problems with that is fatigue. Fatigue is going to be common with working with them, and how they're feeling is vital. So you may have worked with them on Monday, and they seem fine, they handled that workout very well, but on Wednesday, they can't do anything. And that's why, yes, it's good to have a plan going into each workout, but being able to be flexible and moving it around is also just as important. And this was something I also found very fascinating, is that multiple sclerosis gets progressively worse throughout the day. So exercise testing and exercise in general should be earlier in the day to avoid the length of day that they are having to have, because as it progresses more and more to night, they're less capable of doing exercises and movements they may have been able to do during the morning. And avoiding testing during symptom exacerbation, this is essentially when they're suffering, when they're having difficulties, don't push them past their limits. And as I've said before, blurred vision and fatigue, coordination and balance is going to be an issue. So right down here saying straps for exercises, you may have to strap their legs into bikes because they'll have spasms that may cause them to move out of them. Or having them do something like a treadmill might be very dangerous unless you have like a hip stabilizer, just so if they do slip and fall, you have them held in place. And that's why a recumbent step ergometer may be better as exercise testing, as it doesn't localize fatigue. You're not going to exhaust their legs to the point that they have more spasms there and are unable to do the exercise. And you may have to use exercise bouts. So yes, for testing, you're just trying to get a baseline for them and see where you can go and where you're starting from. But you may have to take a 10-minute walk test or 6-minute walk test, more likely, and make it 3 2-minute walk tests and average them out and see where to go from there. So some important overall guidelines, and these are going to apply not only to exercise testing but exercise prescription as well, is exercising early in the morning. As I've said, straps are beneficial. Use initial performance tests to assess endurance, strength, gait, and balance. Essentially, this means you want to get an overall idea of who you're working with, because sometimes the disease is going to make them seem as a completely different person of what they actually can do. And avoiding overheating when the environment or by creating too high of an intensity. So when they overheat, the symptoms exacerbate themselves and it becomes more difficult. So keeping them inside in air conditioning or pushing them too hard, or by using moderate intensity instead of vigorous intensity, you're able to avoid this. As I've said, bouts of exercise, and then really because of the specificity that assessing joint range of motion and flexibility is going to be important for your baseline. So some prescription guidelines. For those that are not as highly disabled or they are in the initial phases of MS, guidelines are considered with a normal healthy adult. So refer back to that chapter when you're dealing with these patients, but most likely the ones that you'll be seeing more of are those with, as I've said, the relapsing, readmitting MS. And as symptoms increase, there will be a change in the ability and their ability to give a certain level of work effort. This may seem obvious, but as the disease increases, they're less likely to do what they have done months prior, and this makes it really difficult to progress them from stages of exercise. So you might not see a linear and exponential curve in their strength or aerobic output. You may see something more so like they're doing really well and then an immediate drop off, but then at least holding them, trying to maintain them is going to be much of your priority. And as I've said before, changes are needed day by day. So here are just some overall prescriptions for exercise, or for exercise prescription. Is intensity moderate, 40 to 70% of VO2R, or an easier way to do it that is much more working with them and seeing where they're at is using RPE and aiming for, on the 6 to 20 scale, 11 to 14. Now, frequency for aerobic is 3 to 5 days a week, depending on their level of disability. And also, most likely in the beginning, you're going to have to start at 3 and progress to 5. Don't try and throw someone who's dealing with chronic fatigue, chronic weakness, and have them jump into 5 days of training. And time. A good goal to start is 10 minutes. And then once they can handle 10 minutes, then begin increasing intensity and then beginning increasing time. Yes, as I've said, if you have someone who is out of the stages or has just begun MS, you may be able to start with that 20 to 60 minutes. But for those with much further into MS, you may have to start at 10 and go from there. Now, using whole body machines to avoid isolated fatigue may be needed. And that's such as the recumbent stepping machine, cycle ergometer, arm ergometer. And walking is possible, but very case by case. It's most likely going to be your people with MS who have just started the disease. So, and progress slowly. Resistance, intensity of 60 to 80% 1 rep max, 2 days a week with 1 to 2 sets of 8 to 15 repetitions. Keeping aware that fatigue is going to localize itself, so trying to avoid doing back-to-back muscle groups is going to be very important for them to get throughout the exercise. So most likely what you're going to do in a normal day is have them do maybe upper body and then immediately go to a lower body exercise and then go to a core and then go back to upper body. So you're avoiding the chronic overkill of one muscle group. And as well, slow progression and preparing for setbacks. Flexibility, now as I said before, flexibility is going to be very important with MS patients. And stretch to the point to tightness or discomfort, but no further. If you push it further, spasms may arise themselves without any other need for evocation. So frequency, 5 to 7 days a week and 1 to 2 times a day. Now this is going to be very difficult to implement, but if you think about it, you have to have them do resistance exercise 2 days a week. You have them do aerobic exercise 3 days a week. So if you just alternate Monday, Tuesday, Wednesday, Thursday, Friday, yes, that's having them work out 5 days a week, but the time would be very low. You're also dealing with their time constraints, but you could have them do, for the end of their sessions, flexibility, and trying to have them do it at home or by themselves. Time, hold 30 to 60 seconds for 2 to 4 reps of each stretch that you're trying to do, going for major muscle groups and avoiding, as I've said, going past the point of discomfort to avoid spasticity. Now, here's just a fit example. For a 45-year-old male with MS relapsing remittent, 5 days a week, 3 aerobic, 2 resistance, and 5 flexibility. 5 flexibility being at the end of each set, and possibly in or before. Aerobic, 3 days of 10 minutes if able on cycle leg ergometer or recumbent step ergometer with 2 days of resistance, full body each day, ensuring 1 day rest minimum between resistance days. And 5 days of flexibility, 2 times a day if able or at home given. Intensity for the aerobic, 40% VO2 max, just as we're starting out. And then 1 set of 8 to 15 at 60% for the resistance. And this is working on all major muscle groups, avoiding issues in the range of motion, and where fatigue will build up quickly. And flexibility work to ensure safety, similar to resistance, not pushing them past what they could, not pushing them to the point that they cause injury. And here's the thing that I've said many times, but I want to really stress, is progressing as able and avoiding training during those relapse phases. Because if you progress them too fast, you're going to see even more relapses. If you progress them too slow, you may not see the same outputs. And so it's really hard to find that middle ground, but it's something that's very important for these patients. Now, some special considerations, there's a lot of them to go over for this group. Stretch high spasticity muscles often. Once you get to know your patient, you'll know where they suffer the most from, and you'll be able to help them in certain areas more so than others. Now, yes, if you focus on some areas, some may fall back, but at least working with them to keep them as safe as possible is going to be very important. Now, functional activities, you got to think that this is a lifelong injury and disease that affects their daily living. So having them do functional activities. So instead of having them do squats, have them do sit-to-stands. Or instead of having them do bicep curls, have them do something as simple as just moving like dishes. Because these are the things that they're going to really miss in their lives. Yes, it might be great that they can pick up certain weights, but it's going to be much more practical and especially helpful for them at home if they have these skills that they may have lost because of the disease. And a constant RPE check. Because something with these patients, it could change like that. You got to understand that this is the nervous system, and that neurons fire at speeds that we can't comprehend. So they may be doing really well at one point in time, but all of a sudden will just drop. So you really got to look for this and keep in contact with them. Even if they're in the middle of the set and they've been doing great for 7 minutes, at 7:30 they could have injury or have a consequence that you may not see unless you're asking them. And checking the medications, because some of them have flu-like side effects, so this may make them sick, and just working around sickness as well as remittent phases. And fatigue should decrease with increased activity level. So yes, when you're dealing with them at the first part, and when you're meeting with them, their fatigue level is going to be at an all-time highest, and you've got to stress to them to not get discouraged and work through this with you. So also, you have to teach them in this, educating them on multiple sclerosis fatigue versus exercise fatigue. Now, I personally can't comment on multiple sclerosis fatigue, but with exercise fatigue, you as an exercise physiologist you should have very much training in this, and you should know what to explain to them and how this is different. Because the fatigue that they're feeling from their disease is going to be a constant of nature, where the exercise fatigue is going to be just after exercise, and it's going to actually make them better. And it's going to be teaching them the difference is going to be very important. Obviously, avoiding heat and outdoors in hot months and using fans if needed. And as I've said, they may not have a linear progression, and just like in that, they may not have a linear heart rate and blood pressure responses. And this is called dysautonomia. Dysautonomia essentially means that their heart rate will not elevate with the intensity level. Their blood pressure will also not do the same. So just being okay with that, but still monitoring it for arrhythmias and such of that. Fluid intake, because of the nervous, they've lost some of their bladder control. So you'll have to watch their amount of fluid intake and make sure they're not going way over it. Also, with part of the MS is cognitive, and just working with them on this and explaining things, working with them, being them in the moment is going to be very important. Now, last thing, and this is something that you shouldn't have to worry about, but Uthoff phenomenon is the worsening of the neurological symptoms, vision, temperature are elevated, and this is something that comes from the disease, and you just got to be careful of. So, I thank you guys for listening to my presentation. Hope you guys have a great day.